Hello, this is Derek Hansen for StrengthPowerSpeed.com, and this is our 14th episode of our Performance Concepts Chat. In this episode, we're going to be speaking to a physical therapist, local physical therapist, friend of mine, doing a lot of interesting work. We'll get into the details of that. I just want to comment, last weekend I had the opportunity to present at Ranfone Training Systems in Hamden, Connecticut, and had a great time. The people that showed up, very intelligent. Michael Ranfone himself, very passionate, very intelligent as well in terms of the questions, the conversations we had. It was a great time. I had to present for 2 days, and it felt like it just went by really quick. It was just high quality discussion, good people. I had people like Charlie Weingroff there. Great to have him contribute. Other people that were there, Jim Ferris, Chris Wykus, Trevor Rappa from I'm wearing my Resilient shirt. I'm good friends with Doug Sheegian as well. So, I just love getting together with people like that. Had Coach Eric Klein from Connecticut, formerly at Minnesota. Just some great people, and when I come away from stuff like that, events like that, it just drives me to learn more, learn from other people, talk to other people. And it's nice to go to a conference, I guess, where there's multiple speakers and you get some variety, but sometimes it's good just to for 2 days straight and just talk with people. And that's where I get value in terms of sharing my ideas, but getting feedback from them and figuring out, okay, are we all moving in the right direction? Are there some things we can improve? So that's a great part about those types of events, and hopefully I get to be involved in more of those. But in this talk, another good example of just sitting down with somebody and hashing out ideas, finding out where they came from in terms of their development, but also things that they're looking for in terms of being innovative. And the guest I have is Dean Kotopski, and very passionate about his work in the physical rehabilitation side, physical therapy. He was also working as a massage therapist for a period of time. So lots to draw on from there. And we get into the details of his approach. He has a very specific approach that he's, developed, refined. It's called the force balance technique. He'll talk about that. But also this idea that he's using other therapies and drawing on other experts. And we get into this discussion of injectable therapies and ultimately stem cell therapy, which, is here, whether or not it's been perfected. But I like what Dean's talking about in terms of surrounding that therapy with his process, his technique, his system to maximize the benefits, maximize the results with the people he works with. And people in the physical preparation field, you really have to align yourself with good people in the physical rehabilitation, physical therapy side, the medical side, because you can't have one without the other. You're going to have athletes get hurt. You have to be part of that process. You have to have good people to send them to. And I was lucky in that I was mentored by people like Rob Panarello, Joseph Horrigan, Donald Chu, people who all have their hand in both the physical preparation and the medical side and the rehab side. So that's one thing that you'll get out of this is you should be adept at talking about the rehab side, the medical side, even if it's not within your scope of practice. Learn more about that, and hopefully this talk with Dean gets you thinking about that and how things are going to look in the future. So this is a great talk. I'm looking forward to getting some feedback from people. So have a listen. Let me know what you think, and we'll be talking with Dean in the future for sure. This is just the start. Kind of sets the tone for future discussions, and I will be talking to other rehab professionals as part of the podcast as well. So enjoy the talk with Dean, and we'll check in later. Okay, Dean, I wanted to speak to you specifically about rehabilitation, return to play, whatever you want to call it, the medical side. Most of the podcasts have been about physical preparation, getting people ready from the training side. And I felt it was time to talk to somebody like yourself. We'll probably talk to Rob Panarello, maybe a few other people, but you're local. I've had a chance to work with you. And right now, you have something ambitious planned in terms of a comprehensive service that you want to provide on the return to competition, rehabilitation, pain management, just the general health and medical side. Before we get into that, and we have a lot of little details to cover, can you give us some background on what you've gone through, why you got into the rehabilitation field, what drew you in, and then how it's evolved over the years?
Yeah, sure. So my journey began in 1988. I came down to the Lower Mainland from Kelowna with a head full of steam. And I was attending West Coast College of Massage Therapy. I was 20 years old, I guess, at that point. So
and that's something you knew you wanted to do, massage therapy, or?
No, not completely. I had been very interested in some sort of medical career. I didn't know what yet. So, truth be told, I wanted the least amount of time that got my feet wet. So this was a 3-year commitment, versus like a 6-year commitment for chiropractic or physio school or something like that. So I wanted to get my little bit of introductory to whether or not I actually wanted to work with people in this capacity. So the long and short of it is, we came down, did that, loved it, absolutely loved it. So that started me on this quest, this path to figuring out how to develop a treatment system for people. It was within about 2 years of practicing as a massage therapist that I realized, once again, I loved it, but I was ill-equipped, and I don't mean any disrespect to massage therapists. I just wasn't fixing people. So that led me to...
I assume you got some limited results, though, like in terms of...
Oh, for sure.
Yeah.
No, absolutely. Yeah, no, massage therapy is a fantastic... I mean, we can talk about this now or later, about my beliefs in that, but in terms of results... yeah, absolutely. I was helping people. The general feel that I was having, though, was I wanted to be able to do better, and I wasn't.
Okay.
So, yeah. So I had to make a decision at that point. I actually thought I was going to go into med school. A friend of mine's a doctor. He mentors young pre-med students and stuff like that. So we were kind of preparing me for that, and I had a heart-to-heart with myself, and realized that I'm a mechanic at heart and a tinkerer. And so I knew physical medicine was definitely how I wanted to practice.
If you went into the medical field, would you have gone into something like orthopedics? Surgery?
Yeah, physiatry.
Okay.
Yeah, physiatry for sure, which is a physical medicine doctor. They just don't really treat per se. Mechanically, I mean.
Okay.
So I had to make a decision, and the big three really are osteopathy, physiotherapy, and chiropractic. So I decided on physiotherapy. Physiotherapists have the largest scope of practice here in BC, so and I knew I was going to work in BC, or I wanted to anyway. So yeah, I began upgrading a lot of courses and working my way towards going to UBC. I wanted to go to UBC, either there or Australia. Australia and New Zealand have actually really good mechanical programs. So does U of A actually in Canada. But I wound up getting into UBC in '99.
Great.
And started my physio degree there and graduated in 2002. And about 2 years after that, I got my acupuncture designation.
Okay.
Through CAFKI, or the Acupuncture Foundation Canada Institute, and started doing acupuncture, and then I learned IMS, and that's I've done lots of courses here and there
Mm-hmm.
and along the way, but that's basically the bulk of my academia.
Okay.
So yeah.
And as you even went through that process from an educational point of view, were there things that you pulled from that and said, okay, this is really valuable? And were there some things that were maybe not so satisfying, or like, I don't think I've got the full answer here?
That honestly is the $64,000 question. That is the big issue. So the way I view this is like this. So since I was old enough to use a tool, I've been kind of twisting wrenches on things.
Mm-hmm.
My dad at that time, we always had a shop and tools to work with and stuff like that. So.
Nice.
I was very, always kind of looking it's funny. My brother and I would get Christmas gifts, and he would play with his, and I would take mine apart, right? So I was always kind of interested in movement and how things worked, and I got into cars really early on. Kelowna was a hotbed for that scene.
Okay.
In the 70s and 80s and stuff. It was an awesome place to grow up at that time. So, my first car at 16 was a 1970 Chevelle.
Wow.
With a bit of muscle and stuff, and it was game on from there, right? So I actually thought at that point I might be a mechanic. Like
Mm-hmm.
I was starting to actually. I got a job at Canadian Tire doing, working in the shop there, and
Mm-hmm.
just doing light tune-ups and oil changes and tire changes, and learning as much as I could, and I loved it. And then one of my friends' dads told me about massage therapy, and I was working out at the time, and I've always been athletic and interested in that field as well, and that's how I wound up at massage school.
Okay.
But truly, it was my love of mechanics and the intricacy of how things move and work that led to all that other schooling. And the main reason, to get back to your initial question, about the what is valuable and what isn't, and what sort of led me to understand all of that path, was the fact that everything's valuable. They're all tools. They're truly, when someone asks me, what do I think is better, massage or physio or chiro or needling, that's literally, you're asking me, what do I think is better, a screwdriver or a wrench or a hammer or an impact gun? That that question doesn't have a basis of logic, really, because those tools are all essential
Mm-hmm.
in fixing the car, if you will. So early on, I realized as a massage therapist that I didn't have all the tools. I had my hands, and I had a set of knowledge-based skills with my hands. But I wasn't able to, I didn't have a toolbox.
Mm-hmm.
In fact, one of the questions they asked me at UBC during the interview was why I wanted to stop being a massage therapist and get into physiotherapy. And I said, I absolutely do not want to stop that form of practice. I just want to add to my toolbox.
Okay.
So I can deal with patients, from an acute variety, and be able to deliver a little bit better, more well-rounded approach to their treatment. And much based on how I would fix cars and how I was learning how to fix the mechanical world, right?
And certainly having that knowledge is going to make you more valuable as somebody who can refer to a massage therapist, and knowing what that process involves, and maybe giving specific recommendations to the massage therapist you refer to. So yeah, I think expanding the knowledge in that regard is fantastic.
It's a big deal. This is a whole other can of worms, man. This question and this theory pervades every day I treat, and ultimately, I think that the system, unfortunately, is a bit flawed. What I would prefer to see is one school. Where you take your 4-year undergrad, if you will, and then 4 years of specialization,
Mm-hmm.
where they teach you how to use your hands, how to exercise appropriately a client, how to manipulate the skeleton properly, how to needle the soft tissues
Mm-hmm.
and affect the neuromuscular system, and then apply that with some basis of treatment, like force balance technique. So unfortunately that system doesn't exist. So we are left with a system that you have to, I liken it to, I've often used the analogy of if McDonald's served hamburgers and Wendy's served fries and Burger King had drinks, and you wanted to have a Happy Meal, you got to drive around to all these places to get your full meal.
Sure.
And that's essentially what we're doing in the physical medicine. And unfortunately, that doesn't yield the best results we could be giving the general public. The general public suffers. It absolutely makes no sense to me, it never has, why our chiropractors here are unable to needle a muscle to affect that muscle in a positive way so they can manipulate a joint. I don't want to pigeonhole chiros as just manipulative therapists, but sort of the vast majority of what they're doing. But we're not giving the therapist the best tools to be able to get a better outcome for that client. Mm-hmm. So really, and this goes across the board, a massage therapist that could needle would be phenomenal. Mm-hmm. Massage therapists that would involve remedial exercise as part of their routine, once they've gained some range with that client, to be able to actually take that joint and that neuromuscular system through proper range and load for durability effect. That's really truly what I've been shooting at my whole career.
But it's interesting you say that, because some of the other people I've interviewed over the last couple of months have talked about this tendency for us to gravitate towards specializations. And so this is what you do, this is what I do. And people think it just works better, or it divides the territory better, when it seems that a generalist approach would be more effective. Would you agree?
I absolutely agree, and I'm going to just go to the research. So the model is interdisciplinary care. So the difference between interdisciplinary care and multidisciplinary care is essentially multidisciplinary care is a group of professionals working under one building, and they kind of all do their thing. The great word that you used was divide. It absolutely divides us up. Mm-hmm. Interdisciplinary care actually has one head clinician, or a few perhaps, mm-hmm. that are working with the client load, and they're assessing and they're determining what is going to be the treatment plan. And by far and away, the research shows huge positive correlation and higher outcomes in that model of treatment. So it's essential that any multidisciplinary facility, hopefully they're communicating amongst each other, inter-referring. I mean, I know some clinics that are basing their inter-referring relationships on monetary gains.
Oh, sure.
And, so you'll get a kickback. If you send me clients, I'm going to kick you back some percentage of like that. Actually, first of all, it's unethical. But hey, man.
When has that ever stopped anybody?
Yeah, so that's certainly not our approach. But unfortunately, like you say, there's been a trend more towards specialization and fragmentation. Mm-hmm. So when we divide the subsystems, we immediately are setting up that system to fail, in my opinion, because once again, if all you have is a hammer, everything looks like a nail. You can't fix the car thoroughly with just a wrench. Mm-hmm. I can do some things really well, but if I just keep wrenching you and asking you to come back every Tuesday and Thursday, what are we accomplishing? What mm-hmm. are we achieving? Mm-hmm. Right? So that's what force balance technique, the system that I've
and we're going to get into that. Yeah. And let's start with kind of the question I had was, you work a lot with athletes. I think let's be honest, that's kind of your bread and butter in terms of your expertise, working with the high level athletes, getting them back on the field, the court, the ice, whatever. Mm-hmm. Can you talk a bit about those successes? But also I want you to kind of roll in there, what do you do for athletes that helps you become a better physical therapist for general population? How does that work?
Well, truly, in my opinion, that's where the action is. Mm-hmm. Let's analogize again. The mechanical gains that we see and technology that we see in cars for generic you and me, a lot of that stuff trickles down from F1 racing, like the
Yep.
racing technology, right?
Mm-hmm.
So really that's where who's pushing the front of the wave, right? It's the same with athletics, truly. You've got an industry that is or an individual that's pushing his body or her body to the extreme. So these people need results. You can say anything you want to these guys, but if you can't deliver, they probably aren't going to want to work with you too much.
Mm-hmm.
So my whole career, from the get-go, has been predicated on the need and the necessity to get results, and results fairly quickly, and durable results, things that last. So the one thing immediately that I learned from that experience, and that has been pushing me, has been, you got to bring it. For example, we have, I've been using AutoSound in my clinic for, I think it was the first one to have one of these in the province, certainly in Western Canada.
What's the difference between like conventional ultrasound?
So just very briefly, the wavelength and waveform and all of that, there's no difference between the sounding head that you would manually use or our AutoSound applicator.
Okay.
The only deal is that unfortunately ultrasound with a wand is usually delivered with a 5-6 minute, perhaps 7 minute treatment if you're lucky, which does has little to no effect physiologically on the client. It took me a little while to figure that out. AutoSound is in-place sounding. And like I said, I needed a way to settle down inflammatory issues with my clients pretty quick. And I knew ultrasound, the actual physiology behind it was valid. It's just, unfortunately, the way we're applying it isn't valid.
Yeah.
So we stepped it up even. So I'll do like a 20-minute to half an hour ultrasound application, which it's funny because I'll have clients, sometimes they'll be in a medical forum and they'll mention this, and a physio or some athletic therapist will hear and they'll think they're confused.
Okay.
They think they're having a stim session,
Gotcha.
which they're not. They're actually getting ultrasound. We stepped this up a little bit too. We've been using dexamethasone and other forms of medication to create whatever sort of desired effect we want.
Okay.
And we do phonophoresis, which is not new.
Yep.
You can do it with the handheld stuff too. It's just, once again, you need a fairly decently long application to get a beneficial effect.
So the duration is what most people are missing.
It's a big deal.
Okay.
It's a big deal. And so, once again, dealing with athletes, you see very quickly if the modalities you're using are effective or not. So that's what I brought one of my friends from in Florida, working with the Gators, had sort of keyed me in on this way back when, and I would tell a look and I'm like, man, we need one of these things. So anyway, yeah, so that, and it works very well, by the way, for what it does. But so truly, athletics and sport rehab, if you will, sports sciences are kind of what you get that trickle down effect, much like you would in the automotive industry. So you're pushing the forefront. Usually you're going to find a lot of the cool things are being done with the athletic population.
Yeah, so whatever Honda's doing in F1, it's trickling down to what they do with their passenger cars.
Yeah,
okay.
man. Yeah, absolutely.
Okay. So Dean, we've talked about your philosophy behind how you put all this together, and I want to hone in on the FBT, the force balance technique, and how you're using it with athletes, because I think that's where it started for the most part. Like, that's a high performance example. You're working with a race car, you're tuning it exactly to the specifications you want, putting it on the road, making sure it works. What are some examples of how you applied the force balance technique effectively and said, okay, this is where I'm going?
Mm-hmm. Yeah. So there's probably the most poignant example of that was a number of years back. I had a professional football player that played for our provincial team here. I won't say his name. He was referred by a sprinter friend of mine. He set him up to me because he was having some hamstring problems, chronic hamstring tears. And I think he had 3 tears within about an 18-month period. So we brought him in, and he one of the first words out of his mouth was, "I've lost my first 2 or 3 steps," meaning my power's gone, my speed, my start, my explosiveness has diminished significantly. And my bells went off, the alarm bells went off, because reduced hip flexor power is a symptom of malalignment in the pelvis, obliquity. So,
and you told me, you told me the story, but you said he's gone through all the conventional therapies and things, and nothing was working.
Yeah, like I say, this is 18 months later, man.
Yeah,
and, you know, he'd had pretty much everything. He'd seen a number of hip specialists, low back specialists, his team physician, his AT, the PTs, and so we did. I did my standing, my weight bearing testing and ranges of motion, my non-weight bearing ranges of motion and testing. And he had a fairly significant anterior rotation of the right innominate bone, the right big pelvic bone. And what that does, immediately I knew that there's a correlation between the weak hip flexor power. But the other thing that it does is it puts the hamstring on length. So if you anteriorly rotate your pelvis, the one side of your pelvis forward, the hamstrings hook onto the bottom of that bone. It's called an ischium. And when you anteriorly rotate it, that ischium rises superiorly. So you're effectively lengthening that hamstring, putting it on a preload or a pre-stretch. We know the vast majority of hamstring tears happen in late swing phase of gait, and it would make sense too, because the muscle is pre-lengthened, so it's the length tension relationships have been affected. At any rate, he was going through this problem of tearing. So we correlated that with the loss of power. I tested him with my dynamometer on his left side was perfectly fine. His right side was, man, I pushed him down with 2 fingers. We did a straight leg, the muscle test for psoas, and just nothing there. In fact, he wanted to repeat the test 2 or 3 times because he himself couldn't believe it. We got a professional athlete here.
And you're showing that he's weak. He's very weak.
Like incredibly weak.
Yeah.
So, and by the way, this isn't uncommon. I see this pattern consistently in high level athletes. So anyway, at any rate, we long and short of it was we worked with him for it took about a month, but within the first 2 weeks, we had hip flexor power re-established, bilaterally symmetrical, super strong. And he was training at the time. He's had to keep training, so we kind of backed off his program a little bit, did some eccentric loading with his hamstrings, and I don't want to get too technical, but got him balanced out. He could sprint very effectively within about 4 weeks.
Okay.
And he basically picked up where he left off like 18 months ago,
Yep.
minus the hamstring tears. So that's one example of using that in a high level situation. Since then, that's really when FBT started to come together, and I've done that process now with literally hundreds of clientele with chronic low back, hip, and knees, and consistently across the board, the vast majority of these people coming in are showing me obliquities in the pelvis, among other things. But it's that pelvic obliquity that's not being identified, and even when it is identified, it's not being treated effectively, in my opinion, to give long-standing durable relief there.
Because I know from my experience, you'll often have a physical therapist say, they'll do those tests, you're weak, and then they'll try to strengthen you through it.
Yeah.
Now, what's the problem there?
Well, like we mentioned before, right? Like that algorithmic process of mine, I've tried that many times before. We have, and there's a bunch of things that wrong with it. Number one is that you're essentially establishing or enhancing improper recruitability patterns. These patterns, you're reinforcing bad habits. Actually, you're strengthening the problem strong, right? Versus actually trying to, if strength is your outcome measure that you're trying to affect, we get back to the situation where not understanding that there are three other components that build strength, right? So that's essentially the nature of that, why processionally we're not getting people as better as we should. The other thing that happens as a result of that is you can injure the person even further. And I see that happen constantly. And the big problem with that is that athlete or that individual starts to get really desperate at that point, because they, a lot of my clients that aren't athletic, aren't professional athletes, they will take it upon themselves to go into a gym and say, okay, look, I'm probably just not doing enough work. I'm going to abandon my other protocols, and I'm just going to go and just, hammer it out in a gym. And I get it why that happens. Unfortunately, you're not going to get the outcomes that you want. So that whole strengthening something strong prior to making sure you've got good alignment, joint stability, and mobility can be, disastrous is a pretty dramatic word, but I've seen a lot of disasters as a result of that.
Yeah, and so we talk about the technique, and you've given us some conceptual ideas of what's going on there. Where's the meat and potatoes? You talked about your use of acupuncture and needles. Where does that fit in terms of, you've established weakness, you've established asymmetry, you've established shortening in areas. What do you do with the needles?
Well, so if we look at the overall picture, really, I'm fixing you like I would fix a car. So if I have to get at whatever that's broken in my car, I pull out my wrenches, I loosen the bolts off, I do the work, I realign, replace whatever we're going to do, and then we tighten the bolts down. Now, there's a lot more to it than that. But essentially that is the crux of it. With specific respect to needles, needling, acupuncture, IMS, that kind of thing. I use that primarily to reduce pain.
Okay.
So acupuncture specifically, in situ needle, to reduce pain. And then the IMS, I'm utilizing that to release muscular tone and tension via the nervous system. So, and I use, massage, like I'm a massage therapist too, man. So, mechanically I'm doing some massage with them. I'm using a lot of tools to do that loosening part. So the needles are beautiful. This is what I was referring to before. If we could actually, I believe that if we would allow our our chiropractors here and our massage therapists to use needling in their practice as well, we would have greater effects with what they're trying to do. Being able to loosen a muscle that's in spastic guarding prior to adjusting them, you're gonna have
if they're sympathetically dominant, right, and you're trying to pound away at the muscle. I mean, you know how that how futile that can be.
Yeah, you flare everything up, and you wind up getting the opposite effect, right? So yeah, needle. I've often said if I had to keep one tool other than my hands, it would be the needles. The needles are profound in terms of being able to relieve tension, calm a patient down, it's fantastic.
Now, going beyond that, the needles, manual therapy, obviously you can incorporate stretching. If we get into some of these injectable therapies that you've had experience with, so we can start with prolotherapy and then how that sort of transition into use of platelet-rich plasma therapies. Can you talk about that?
Yeah, even prior to that, the PRP, before we're looking at doing any sort of injecting around the joint, which is a big deal, or inside the joint as well, intra and extra-articularly. We're also looking at the patient overall. Let me give you a case in point here. I'll get a client into my office that's in chronic pain. Their nutrition may not be the best. They're for sure almost always, their sleep patterns are not great. Unfortunately, what that does is it elevates something called cortisol in the blood. Cortisol is your anti-stress hormone, and it's basically like nitrous oxide for a funny car, a fuel car, right? So you're running on this high stress hormone. You're frazzled at that point, right? That runs a cyclical pattern in that pain tension cycle that's negative or counterproductive for you. And you're going to report higher levels of pain. In fact, there was a study done a while ago on shoulder pain, and all they did with the control group was manage their pain levels at night, their PM pain, and within about 3 weeks, there was about 70% less reporting pain with no other change to their therapeutic regime. So it's a big deal, right? So physiologically, we want to make sure that our patient is, I don't want to be too generic with the term balanced, but truly that's what we're trying to do, is get them as homeostatic as possible.
So it's not just structural balance, it's everything. It's hormonal, metabolic, psychological, that you're taking a look at all that.
I mean, we're talking about Engels' biopsychosocial model, right? That's been around since the 70s. But yes, in a nutshell, yes. I'm just a mechanic, Derek. That's what I do, okay? But I could be the best mechanic in the world, and I still won't win the battle with pain. Improper nutrition, poor psyche, depression, that sort of thing. So we in our clinic, and part of FBT really is a physiological process where we're trying to stabilize that client and get their pain levels settled, get them sleeping better, educate them about nutrition, and a lot of proper health is just drink lots of water, eat good food and get proper rest, right? And we're a lot of times when we assess that client, the basics haven't been covered, right? But yet we're trying to do these complex, fancy forms of treatment with them. That's not acceptable, right?
Yeah. Well, it's interesting. I mean, you talk about pain and this whole issue of addressing the pain. If you're in pain, guess what happens? You don't sleep. You eat crappy because you're like, oh, I'm in pain. I just want to eat something that makes me feel good.
Carbs,
yeah,
right?
Yeah, right. So I can see
which
how
creates inflammation. So yeah.
Which is a whole other topic again. But
we'll get into that later.
But I think looking at this as a global problem that you have to solve on a multi-tier level is interesting, and I don't know if everybody's doing that. I mean, based on I'm sure we're not here to talk about other therapists, but I'm sure you have a lot of people coming to you saying, wow, this hasn't been done with me before.
Yeah, unfortunately, yes. That's we hear that a lot. I want to change that. I really want to see a more consistent assessment regime, source identification, and proper treatment regimes that it's not acting out of your scope of practice. If you're educating your client as a mechanical practitioner, it's not acting out of your scope of practice if you educate your client on proper nutrition and provide them resources on how to manage their pain levels and so on and so forth. And guess what? At the end of the day, you're going to wind up getting better results with that client. It's going to be a lot easier to treat them.
Yeah. So we've talked a bit about, use of needles, some degree of injectables. If we get into PRP, platelet-rich plasma, you've been doing that for a while now. And so how does that fit in terms of the preparation, addressing the issues, whether it's pain, degeneration? What has been your experience using PRP?
Great question. So it started with prolotherapy.
Yes, sorry, the other P.
I missed the prolo. Yes, and the difference is dextrose or prolotherapeutic injection versus PRP or platelet-rich plasma. And platelet-rich plasma is simply us drawing your blood, centrifuging that blood, and separating it into plasma, which is rich in platelets, and other things, white blood cells, so on and so forth, and then the red blood cells, the RBCs. So we can draw off that serum or the plasma and re-inject that into sites that we want the desired effect. So
and what does that do? Like if you're injecting that, it's super concentrated, I guess. What's happening at the tissue level?
Yeah, so basically what's going on is growth factor and other infiltrates come in. Some of the growth factor can create new growth. really what is happening is there's an inflammatory reaction that's created. That sets into motion a cascade of events. And ultimately what happens is collagen is brought into the area and can be laid down. So collagen forms, type 2 collagen forms a large part of the white tissue when you look on any anatomy diagram. So that's your fascia, your tendons, your ligaments and joint capsules, your discs too, your IVDs and stuff like that, your menisci. So I just actually had PRP done on my knee a week ago. I don't want to be too testimonial-ish here, but we did prolotherapy on my right knee for a meniscal tear about 5 years ago now. And I was surgical at that point. I had a confirmed MRI, an oblique tear through my medial meniscus, extremely painful, couldn't extend my knee properly, swollen, dysfunctional. And Dr. Chan, my naturopath in the clinic, got a hold of me and said, listen, man, let's shoot this. And I was skeptical, I'll admit, I was very skeptical. We did 3 injections, week 1, week 2, and week 4. And within about a month after my 3rd injection, I was asymptomatic. No swelling, full extension, full range. So I just tore it a bit again. In a jiu-jitsu class about a month ago, and which, by the way, MMA guys love this stuff. They're constantly getting beat up and torn, and but anyway, so I just did it. Yeah, we did a month ago, and I'm 85-90%, and I think actually we got a reduced effect here because I hurt my back about 3-4 days after injection, and you and I were on our way to Denver, so I didn't want to fly, and we were doing all this stuff anyway. So I took some anti-inflammatories. You're not supposed to take any anti-inflammatories for about a weekish after, because you're going to reduce the effect.
Sure.
So I think that's why we got a little bit less of an effect. But I could run and anything on my knee. Actually, in fact, I just played soccer against my daughter's soccer team last week. So and that was within 3 weeks, right? So prolotherapy or PRP, I've been referring for the past 20 years, I guess since 1997.
Do you still refer to prolotherapy? Because I know we were at a conference couple years ago, and there's a woman doctor, she presented on prolotherapy, and she said, well, I was thinking of doing PRP, but the prolo still does the same thing. It introduces inflammation, growth factors, all these things. So I decided to stick with prolotherapy. What are your thoughts on that?
So what we're finding clinically is that, we know this too biologically, is that think of prolotherapy as a lighter and PRP is a flamethrower. So you're going to get a bigger reaction with the PRP. There's times when we may want to do prolotherapy. Mostly we're finding, if we're on a tendon or a ligament that's really near the surface, in and around the hand or elbow, sometimes around the knee, MCL-ish, potentially, we might want to just do prolo. It's cost prohibitive. PRP can be expensive. Prolo is less expensive. But typically, we're gonna recommend, now that we've seen the difference in both. We're gonna recommend typically the PRP. It's a one-shot deal. And you don't really need any more, depending on where you're shooting, mind you. If it's spinal, it's a little different story. But let's say we're going into the knee, for example. It's a one-shot deal, basically, most times. So it's so then you're only having to come in once. And we get a bigger effect. And so that's basically it. She's right. It does create more or less the same biological cascade, if you will. But PRP is the flamethrower. It's kind of like the Ferrari. Prolo's sort of like I don't know, you pick. Lesser than a Ferrari.
Mazda.
Mazda. Yeah, Mazda Speed, which isn't a bad car.
But now we're present day here, and there's new stuff coming online, and you've been involved in not only investigating the efficacy and the different types of methods, but looking at stem cell therapy as part of a progression in your system. Can you talk more about that?
Yeah, extremely exciting stuff. So where this fits in the overall process is, we talked a bit about stability or instabilities, really. and my view on how I think those are far overlooked in when they're assessed, and how we treat them. Truly, Derek, a lot of this has progressed out of my lack of ability to get results. How many more times are you going to bring a client in for treatment?
And let's be honest, you're getting results, but there's still some outliers that you haven't been able to help.
For sure. Yeah.
So you're looking for other,
of course,
avenues.
Yeah, absolutely. And listen, we will apply a conventional methodology. Using that auto sounder. If someone sprains their MCL, we're not typically going to recommend PRP right off the bat. I've got really good means of being able to deal with that stuff with conventional physiotherapeutic means, if you will, manual therapy and exercise modulation and stuff like that. So yeah, absolutely. But where do we draw the line when that client isn't getting better? And truly, honestly, that is the biggest issue. A lot of my process has really been looked at, has been focused on durability. Really, what are we trying to deliver? Because an ice pack can make someone feel better. Touch makes someone feel better, right? We know that. A TENS machine, if you're wearing it, you're reducing your pain signal, if you will. But as soon as you take it off, effect is lost, right? So there's a role for everything in this game, in the rehab game, if you will. But my ultimate goal is looking for quick, efficient, and durable gains, right? So after a certain amount of time, say in a rotator cuff tear with our protocols, if after 4 to 6 visits, you're, depending on the tear, and we haven't imaged it yet, but and you're not responding, I'm starting to look at whether we're on the right track or what can we be doing more of. Certainly there's acuity versus chronicity. You have a different lag there. Chronic problems, the root grows deeper into the ground. It takes longer to dig it out, right? But at some point, the clinician has to really take responsibility for being able to say, I'm not doing anything here. Like, I'm not helping this client, so, and I've seen some pretty crazy stuff, man.
Yeah, and I'd agree in terms of even physical preparation. Like 90% of the time, this is going to work. This exercise or this protocol is going to work. But you have a 10% of non-responders where you have to look elsewhere. You have to look at something different. I'm sure it's the same in physical therapy.
For sure it is. And then, so the skill level, really, a big skill there is knowing when to change your treatment protocol, right? Now, having said that, does it mean a different kind of exercise? Maybe a different parameter of the ultrasound we're using? Or does it mean we better be looking at whether or not there's a significant tear?
Yep.
Has there been an abruption of this collagenous material? And that's where PRP and Prolo and now stem cell is starting to come into fashion. I don't want to say that about stem cell yet. It's here in Canada. It's been very hard to get other clinicians to really adopt the fact that PRP, we do have clinical trial now on PRP. That's been a lot of the problem, is that the research hasn't been there to support this stuff. Yet clinically, I'm seeing this help people, and we're resolving people all along the way. We're at the same thing with stem cells right now. The research is scant. There are little bits.
And you've done a lot of personal research and reaching out to find out more.
Absolutely. I just sent 4 patients down to a clinic in Denver to have bone marrow aspirate derived stem cells injected for knee and low back and shoulder problems. So with the absolute instruction that there's no guarantee, they had to do their own due diligence. I helped them. I sat in on Skype interviews with the physician. They've got a great process, by the way.
Okay.
We were very, it was very collaborative.
Nice.
And there was no smoke and mirrors here.
Okay.
But I actually went to Denver to research the clinic, and I spent the day with them. I was very happy with what I saw. Their process is excellent.
Very transparent.
Absolutely.
Okay.
Yeah, absolutely. And I met with the CEO and the board there, and we discussed things, and I was confident enough to make a referral down, and all 4 guys went and came back, with the exception of one fellow, and he had something called a spondylolisthesis, which is a slippage of a vertebrae on another, it's very difficult to treat.
Yep.
That fellow hasn't had as good results, but the other 3, I would put them all in the good to probably 2 of them are excellent category in terms of response.
Nice.
Yeah, and some of my other colleagues have referred down for stem cells, some what are called non-autologous type stem cells. So they were placental-derived stem cells, which is what I'm looking into. There's an excellent podcast that Joe Rogan just did with orthopedic surgeon his name's Dr. Roddy McGee. And Roddy works with MMA guys, and he's out of Vegas. I've heard of him. I knew Joe had his shoulder done. I didn't realize he had his knee done, but Joe swears by it, like he's cured, right? So we're not allowed to come out and say, and I encourage everyone, it's episode 945 on Joe's podcast.
We can add the link in.
Sure, absolutely. And I encourage everyone to watch it. There's some other, if you go to my website, performxhealthgroup.com, we're just finishing construction actually, so it's May it's the 4th today, so by the end of the week, I've got a few things, we're just starting to upload the resource material on it. I'll have all these things on the website that you can look out and start following that as a resource. But back to Roddy's podcast with Joe, that is essentially a really good look at what is being done in the industry and his take on it. And by the way, he does reference mostly only placental-derived stem cells. Bone marrow aspirate is one of the other types, and so is fat aspirate. So, you do a bit of a liposuction, and you can harvest stem cells from that as well. So
now he made an important point, because I saw that podcast too. And he made an important point. It's not just about injecting the stem cells. There's got to be a support system around that. And this is what you've been talking about.
100%. Yeah,
So,
absolutely.
So how are you, you're going to keep doing what you're doing, but how are you going to support, this therapy? You have somebody going down, obviously you're doing something before, they go down, they come back, it continues.
Yeah.
How does that look?
Yeah. So it looks like FBT. But you're absolutely right. In fact, I didn't mention the name of the clinic, was Regenix out of Denver. Yep. And that's Dr. Chris Centeno down there. He's doing a really good job, in my opinion, of what they're doing down there. But even Dr. Centeno has said this. The CEO of Surgenix has said it. Dr. McGee says it. Everywhere we're talking. The more I talk to people, it's not just about shooting someone with an infiltrate. It is about the process, and I've been saying that for years and years and years now, as I'm developing my mechanical process. Really what that is there was a reason that you broke down. If you didn't have some sort of traumatic onset injury, the vast majority of these are posturally related and overuse related and something like that. So I have postulated, and we've seen there's much research to support this, that we are going to see increased breakdown and wear when you are not aligned, stable, and mobile properly. So you're going to have less of a power delivery system, you're going to be less efficient, and unfortunately you're going to break down. So what I'm talking about is making sure that the reason, if we're going to do your knee, for example.
I had a little reflex.
Yeah, you
there.
did. Sorry. I saw that. That's okay.
I'm healthy.
Yeah. If we're going to do your knee, for example, we want to make sure that we're addressing the causation that brought on that knee problem.
Yeah.
Like I said, if it was non-traumatic, like if you tore it on the field, even if that's the case, we still want to balance you. So, and we want to mitigate the factors that are leading to these unbalanced forces that are creating this excessive and accelerated wear. Back to the car analogy, if we don't align the frame, one wheel's going this way and the other 3 are going this way, do you keep replacing the rubber every 5,000 miles, or do you deal with the source, the malalignment, stabilize it, and now you've got great alignment and proper function at the wheels? Same thing, man. So truly, it's a longer process, but really when people come in for treatment with me, I often tell them it's the difference between a lipstick and paint body job, a little bit of Bondo, versus me breaking you down and building you back up properly. That's the big deal here. And once again, it's more laborious, but our outcome measures are pretty darn good.
They're durable, like you said.
And that's a big deal. It's funny that just on that durable point, how we came about that. My roommate when I was going through rehab med school, my roommate was doing his PhD in economics, and his thesis was on durability. So we spent a lot of time. Something clicked at that point, and I realized kind of what was the part of rehab medicine. What am I trying to do, right? Yes, I'm trying to heal people. Absolutely, I am. I'm trying to improve their quality of life and take them out of pain. Yes, I am. But what's the underlying goal? I want long-lasting results. I don't want you in my clinic for any longer than you have to be. That's what has led to me understanding what Prolo does, what PRP does, what stem cells are doing mechanically for that client, what cortisol, how your physiology affects your mechanical ability, how your psychology affects that, right? That's truly the biopsychosocial model. Really, for me, is the most beautiful way to approach a patient, and we really want to adopt that as best we can.
Yeah, and we go back to this, and we're gonna finish up here, but we go back to your themes again. You know, being a mechanic, treating everything as a larger whole, looking at a system to bring all these things together and make sure all your bases are covered. That's pretty much what you've said this whole time.
Absolutely.
So I'm excited. I think, you know, obviously I'm keeping in touch with you, but we're going to do a follow-up, you know, in maybe 5-6 months. And I'm curious to see where you're at. I know you're piecing some things together, trying to get the right, you know, actors in play for you. And when it comes together, I'm really excited for you.
Thanks, man. Yeah, I really appreciate it. You know, once again, I'm here. You know, I want to serve as a resource to people that have questions. I'm less interested about trying to make you part of our puzzle than I am about actually trying to solve your puzzle.
Yep.
Right? You know what I mean? So, yeah, you know, my website is going to be a big resource for that.
I'll post all your stuff, all your links, contact info, and I know you want to engage people.
Yeah. Oh, yeah. That's the fun of it.
Yeah. Thank you very much, Dean.
Right on, brother.
We'll talk soon.
You bet.
So I hope you got something out of that talk with Dean Kotopski. I'm going to put his contact information, link information for his site and his social media, and somebody you should reach out to, or if you have people in your, you know, area of the country that are doing this type of thing, working with different injectable therapies and looking at tissue regeneration through stem cells. I think it's something we all have to learn more about. And so, you know, provide us with feedback at Strength Power Speed on Facebook, Twitter. That's Strength Power Speed with no vowels. Also, of course, we'll be on YouTube. And, you know, reach out. Let's talk some more about the subject. And it's changing. It's changing every few months, just like technology. And so it's something we have to stay on top of. So thank you once again. And you'll be hearing from us soon at strengthpowerspeed.com.